welcome to you all to the second session of the Victorian Scientific Presentation Evenings. You're very welcome. Looking forward to the evening. Before we start, I'd first like to welcome all the speakers. I'd like to welcome Damian and Daniel, our two judges. I'm Matthew Hadfield. I'm the chair of the Victorian State Committee, and I'll chair the evening. The Royal Australasian College of Surgeons acknowledges traditional owners of country throughout Australia. We're all in different places. Tonight, I'm on the lands of the Wathaurong people of the Kulin Nation, and I'd like to pay my respects to their elders past and present and emerging. And I'd like to acknowledge that sovereignty was never ceded and this remains Aboriginal land. You've all asked the questions. You all should know what's happening now. So without further ado, we'll move to the first speaker. On my list, Michael Flood, you're the first speaker, evaluating the immune landscape of metastatic colorectal cancer. Are you there? Are you ready to go?
Yes, I'm here. I'll just share my screen.
Sure. Perfect. Whenever you're ready, man.
Great. Good evening, everyone. Michael Flood is my name. I'm a PhD candidate and clinical researcher at the Peter MacCallum Cancer Centre and the University of Melbourne. My talk is entitled Evaluating the Immune Landscape of Metastatic Colorectal Cancer. I have no disclosures. So the liver and the peritoneum are the two most common sites of metastatic colorectal cancer. Patients have an 8 to 13% chance of developing peritoneal metastases in either a synchronous or metachronous fashion, which incurs about a 16-month overall survival on systemic chemotherapy. Liver metastases are more prevalent with a slightly more favorable overall survival at 19 months. In recent years, a paradigm shift has occurred in both liver and peritoneal metastasis management, where they are both viewed as a regional disease rather than a diffusely metastatic one, with favorable overall survival, particularly for liver metastases. However, only about a quarter to a third of patients will be offered surgery. This is a highly selected group of patients where tumor biology, tumor burden, and extra-abdominal disease play a significant role. Systemic chemotherapy is therefore mainstay, but issues with poor drug penetration, differences in tumor biology compared to the primary cancer, and frequent systemic chemotherapy failures are common. So further avenues of treatment are needed. To this end, the role of the immune system in cancer has generated substantial interest. From this Lancet Oncology paper, we see the PD-1 checkpoint inhibitor nivolumab showed good disease control in pre-treated metastatic colorectal patients that were MSI high. And a more recent paper from our own lab showed the majority of colorectal peritoneal metastases are stroma-rich and poor prognostic CMS4 hot tumors. Here, this figure depicts the interaction between the host immune system and the tumor and its microenvironment. Typically, the anti-tumor response has been characterized by key players such as the cytotoxic T cell and the B cell. However, flipping the coin, we have cells in the microenvironment that enhance progression and metastatic disease, such as the neutrophil and the M2 macrophage. And lately, research has shown that patient factors, systemic chemotherapy, and surgery have been shown to perturb this balance. So we ask ourselves, do immunological differences or similarities exist between metastatic colorectal cancer sites and indeed the primary? And can we identify avenues of treatment for these patients with no options? So the Peter MacCallum Cancer Centre database was interrogated with 165 peritectomy procedures and over 200 liver resections, and patients who had simultaneous resections of 2 or more evolved sites were selected. I found 20 patients that were identified with varying resections of their primary, their liver, their primary and their peritoneum, and their liver and peritoneum. Using archival fixed formalin paraffin embedded blocks, tissue was used, and it basically just shows that this project has 2 methodological components. On the left here, you see the multiplex immunohistochemistry, which allows simultaneous detection of up to 6 immune-based markers per panel on the tumor sections. And then using machine learning, we were able to assess and quantify immune cell subtypes. And then from consecutive tissue sections, RNA was extracted and levels of gene expression were assessed against an immune-based panel of 780 genes. So going on to the results, here you see a snapshot of the immunohistochemistry and just a sample of the tissues that we encountered. On section A, you see a metastatic site, and C is a primary tumor. And obviously you see the high yellow staining, which is the PD-L1 staining. And that was distributed across all sites when we compared them. So we know that PD-L1 is a protein involved in the adaptive immune resistance, and it binds to the PD-1 on the T cells and it inhibits their effect. Again, we see the metastatic site on the left in B and the primary in D. And we see that the T cells, and if you look at more carefully, you'll see the CD8 cytotoxic T cells in green on the right, and the CD4 T cells, which are in light blue, and these are helper cells also on the right. And again, this translated across both primary and metastatic site, and we compare them, showing that T cells are more prominent in the primary. But it is worth noting that the metastatic sites did have an abundant number as well. So looking at our gene expression, this is a heat map which is generated from the differentially expressed genes. Red indicates a high expression and blue indicates a low expression.
1 minute.
Primary samples on the left, metastatic samples on the right. And grouping these, the relative expression of the genes labeled on the right, you see that the general expression is higher in the metastases, which indicates a high tumor inflammation signature. So putting this all together, metastatic sites are more immunologically inert. They have less tumor infiltrating lymphocytes, though there are immune relevant cells and these are present. They also have a higher tumor inflammation signature, which suggests an inflamed tumor phenotype and potential benefit of immunotherapy, which other studies have shown. Future directions of this data, we look at to compare and contrast between other sites such as the liver and the peritoneum, and looking at the other genes that were differentially expressed and trying to work out co-functionality network analysis to see what they actually do. And also to assess for immunotherapy targets and expression sites for common things such as CTLA-4, PD-L1, PD-1, and TIM-3. These are my acknowledgements, particularly Sandy Harriet, Rob Ramsey, and Michael, who are my 3 supervisors. Many thanks.
Thanks very much, Michael, for that. Great way to start the evening. I'll hand over to my 2 colleagues for questions. Who'd like to go first?
Yeah, thanks, Michael. It was a very good talk. One thing that I didn't quite understand. So in terms of your specimen selection, you essentially said there were 3 groups. So 2 of those groups involved primary cancer and a different metastatic site. So one was liver, one was peritoneum. And then the 3rd group was both metastatic sites, so liver and peritoneum.
Sure.
Then all of the results and the gene analysis and immune profiling and everything was primary versus metastatic.
Yes.
So how do you generate primary versus metastatic from the cohort that was 2 metastatic sites?
Sure. So I've just shown you a subset of the entire analysis that we've actually done. So I've excluded those patients who had their 2 metastatic sites resected, so they're not included in what I've shown. But indeed, it's something that will add to this talk if it was longer.
Thank you.
Thanks, Michael. Damian, any questions?
Thanks, Michael. So just from my understanding, is the implication, given that the immune profile seems to be different between the primary site and the metastatic sites, is there an implication that targeted immunotherapy for the primary will not necessarily treat metastases in the same patient?
Yes, this is the traditional thinking. Metastases were generally seen as cold and not amenable to immunotherapy, but we're seeing it more and more in colorectal cancer. And even in early stage colon cancer, a recent study in Nature has come out to say that we can, even in MSI low or sensitive patients, we can use immunotherapy. So certainly patients with no options who have exhausted all avenues of chemotherapy, it's certainly something that we will start thinking about, and I think we're going to see a lot more research in this field.
Thanks.
Okay, thanks, Michael, and thanks again for your presentation. That was great.
Sure, thank you.
Okay, if we move right along, the next presenter is Nicholas Scarbous. Nicholas, are you there?
Yep, just share screen.
If you can share the screen, I'll just check you can see it. Yeah, great. I can see your screen. So whenever you're ready to start.
Okay. Good evening. I'm Nicholas Scarbous, a medical student and candidate for the Master of Clinical Research at the University of Melbourne. Thank you for the opportunity to present tonight on foot drop after surgery for equinus deformity in children with cerebral palsy. Children with cerebral palsy can develop contractures in their calf muscles causing equinus deformity, and consequently these children have a toe walking gait pattern. Here is a video of a young girl with equinus on her right side. You'll see that during the stance phase of gait, where her foot's in contact with the ground, there's limited contact through her heel, and she's in excessive ankle plantar flexion. Management of equinus is via surgically lengthening the gastrocsoleus muscle tendon unit, and here is the same girl now after her surgery for equinus. There's good correction in the stance phase of gait. However, during the swing phase of gait, when her foot's moving through space, she's still in excessive ankle plantar flexion. And this is an example of foot drop after surgery for equinus. Children with foot drop can catch on their toes as they walk, causing them to trip and fall. And as a result, they're reliant long-term on wearing an ankle foot orthosis. This is a custom-built brace that physically prevents ankle plantar flexion. And here is the same girl wearing her ankle foot orthosis. Most children do not enjoy wearing these, particularly into their adolescence, and this is not a great outcome after surgery. Currently, there's no evidence for predicting which children will present with foot drop after surgery for equinus. And the aim of our study was to investigate the incidence of foot drop and identify any underlying risk factors. We performed a retrospective cohort study looking at three-dimensional gait analysis data of children with cerebral palsy that underwent surgery for equinus between 2004 and 2020 at the Royal Children's Hospital. We compared data collected up to 12 months before surgery to that again between 12 and 24 months after surgery. Our outcome measures included from kinematic data from three-dimensional gait analysis, and that's specifically the maximum ankle dorsiflexion achieved in the swing phase of gait, which effectively measures a child's ability to hold their foot up during swing phase. Via standardized protocols, we included some physical examination measures, including the passive ankle dorsiflexion range of motion, ankle dorsiflexion strength, and selective motor control, which is a measure of a child's ability to appropriately isolate ankle dorsiflexion. And here is it being tested on a child with grade 3 selective motor control. Our cohort included 110 children with cerebral palsy, 36 with hemiplegia, 74 with diaplegia. And from children with hemiplegia, there were 36 limbs that underwent equinus surgery. And from those with diaplegia, there were 115 limbs. And that's because not every child with diaplegia had bilateral equinus deformity. Statistical analysis was undertaken on each of these groups independently, as it's well recognized that children with hemiplegia and diaplegia each respond differently to surgery for equinus. Now for our results. The mean for the maximum ankle dorsiflexion in swing phase in children with hemiplegia was 14 degrees of plantar flexion before surgery and 2 degrees of plantar flexion after surgery. In children with diaplegia, there was a mean before surgery of 12 degrees plantar flexion, and after surgery it was 4 degrees of dorsiflexion. And whilst there was significant improvement in both groups, there was greater improvement observed in those children with diaplegia. And then using this data, we were able to determine how many children presented with foot drop after surgery. In the group of children with hemiplegia, 15 of the 36 limbs had foot drop, which was 42% of the group. And the children with diaplegia, 22 out of the 115 limbs had foot drop, which was only 19% of the group. So there was a higher frequency of foot drop observed in those children with hemiplegia. And the reason for this may be alluded to by the physical examination results in our study. Regarding ankle dorsiflexion strength, in children with hemiplegia, only 25% demonstrated any sort of increase in strength after surgery. And using the Wilcoxon-Stein ranks test, we determined there was no significant change in this group. Conversely, in children with diaplegia, 43% demonstrated improvement in ankle dorsiflexion strength, and this was statistically significant. Similarly, there was no significant change in selective motor control observed in children with hemiplegia, with only 36% demonstrating an increase. In children with diaplegia, 43% demonstrated an increase in selective motor control, and this was statistically significant. And finally, we performed a multiple regression analysis to predict the maximum ankle dorsiflexion in the swing phase of gait, controlling for whether a child had hemiplegia or diaplegia, their level of motor function before surgery, and their pre-operative ankle joint range of motion and maximum dorsiflexion in stance and swing phase. And the significant result of this study was, was that children with diplegia had 4.4 degrees of greater ankle dorsiflexion in swing phase compared to those with hemiplegia. Therefore, children with diplegia demonstrated improvement in maximum dorsiflexion in swing phase, strength, and selective motor control.
1 minute, 1 minute.
Thank you. Whereas children with hemiplegia demonstrated improvement in maximum dorsiflexion in swing phase, however, not in strength or selective motor control. And this group of children with hemiplegia also had a higher frequency of foot drop after surgery. Therefore, we conclude that children with hemiplegia may be more likely to have foot drop after surgery for equinus due to limited improvement in their ankle dorsiflexion strength and selective motor control. Regarding future research, it's been theorized that the antagonist tibialis anterior muscle becomes elongated and weakened with long-standing equinus, and a procedure has been developed called tibialis anterior tendon shortening to help improve ankle dorsiflexion in the swing phase of gait and alleviate the risk of foot drop. And our hope is that the results from this study will inform a surgical trial looking into this potential solution for foot drop after surgery for equinus deformity in children with cerebral palsy. These are my acknowledgements. Thank you to my supervisors and all the staff at the Hugh Williamson Gait Analysis Laboratory. And thank you very much.
Nicholas, thank you very much. That's a really interesting talk. A couple of questions coming up. I'll hand over to Damian and Daniel.
Yeah, well done, Nick. It's a really good study. Quite like it. So a couple of questions. Obviously, being a retrospective study and having so much kind of physical examination findings making up your results, how confident are you in those actually reflecting the truth? As in, are those things accurately measured and well documented for each child that's undergone this surgery? And are they all in a row, or were you sort of having to, get the data from, say, every 5th or 6th child who actually had a complete data set and therefore sort of open to a lot of bias?
Thanks for the question. Great question. So there's a standardized protocol followed in the Gait Laboratory at the Royal Children's Hospital. That's been published and validated in previous studies. It's selective motor control and ankle dorsiflexion strength in particular, are not 100% measures, especially with children with equinus deformity. All children had measures for selective motor control. However, some children did not have an accurate pre and post-op measure for dorsiflexion strength. And so in those graphs, they were the ones that said unable to be completed. I hope that answered your question.
Yeah, thank you.
Thanks for that answer. Damian.
Thanks, Nick. That was an interesting study. So I just want to clarify. So with the results that you've got, there's obviously some limitations in terms of your outcomes, especially when it comes to the hemiplegia patients. So do those limitations outweigh the functional improvement that the patients do get, though?
No, not necessarily. So we use a score called the Gait Profile Score, which is a measure of a child's overall gait pattern compared to a group of typically developing children. And so there was significant improvement for both children with hemiplegia and diplegia in their overall gait pattern. But this study was purely looking at the ankle joint and foot drop to see how many children would develop foot drop and then potentially be reliant on an ankle foot orthosis long term. But the majority did have an improvement in the overall gait pattern.
This is a bit, I guess, ignorance on my part, but if you're only hemiplegic, functionally post-surgery, what's the significance of having foot drop on the hemiplegic side in terms of the overall function? Does it really impair their gait overall?
Yeah, they walk with a limp. So anecdotally, patients and their families will say they're walking with a limp, and it'll limit how far they can walk. Limit, walking upstairs, more functional activities, not just walking back and forth in the gait lab, but real life function. It definitely will. And the only way option out of having a limp is to use an AFO.
All right, thank you.
Thanks very much.
Okay, thanks, Nick. That was a really interesting presentation. Thanks for sharing it with us. We'll move along to our next presenter. Next on my list is Lauren Tong. Are you with us?
Hello, yes.
Lauren, hi. Do you want to try sharing your presentation? Yep, we can see that. Whenever you're ready, you can make a start.
Thank you. Hi, my name is Lauren. I'm one of the students. I'd just like to thank Monash Children's Hospital and then working with an amazing team with paediatric surgeons, radiologists and emergency departments, and my supervisors, Prof. Nataraja and Dr. Pachili. And we studied the utility of sonographic signs to diagnose appendicitis in children. So appendicitis is the most common reason for emergency surgery in children and can be split into simple and complex disease based on whether the appendix is perforated. Children often present as a diagnostic challenge with frequent atypical presentations and often don't have the communication skills to describe how they're feeling. As a result, imaging is frequently ordered, with ultrasound being the modality of choice due to its limited radiation exposure and its convenience. And as you can see, it's got a higher specificity of 94 to 97% and a moderate sensitivity up to 89%. But non-diagnostic ultrasounds are frequent and can be difficult to interpret. So the aims of our study were to identify sonographic features which diagnosed paediatric appendicitis and also further differentiated simple from complex disease. To begin, we did a literature review over 30 years, including all studies which included more than 50 children that had an ultrasound in radiology for suspected appendicitis. And this excludes those who had point-of-care ultrasounds or physician-performed ultrasounds. And children had to have a histological reference standard. We found 20 studies which looked at sonographic signs to diagnose appendicitis, and then 10 which further differentiated simple and complex disease. And to summarize our findings, we found that the sonographic signs utility was highly variable. For example, the presence of an appendicolith was shown to have 16 times more likely in appendicitis children versus other studies which showed it was not significant at all. There was also inconsistent reporting strategies. For example, 30% had a standard pro forma which they had sonographic signs based off, but 80% of these are retrospective, which means that most studies were based upon radiologist data and what they chose to report. And the relative absence of signs was not clear. There was also a large range of appendix visualization rates, with some less than 50%, which meant that they could only see secondary signs of appendicitis, which was when the appendix was not visualized. As you can imagine, there was also population, sonographic, and institutional factors which contributed. So in our study, we performed a retrospective cohort study over 29 months. We looked at all children with suspected appendicitis with an ultrasound and excluded those with previous appendicectomy or another condition causing abdominal pain. Our ultrasound findings were from a standard pro forma, which was institutionalized for many years before our study. We looked at the operative outcomes, including simple and complex appendicitis, and then negative appendicectomies were validated using histological analysis. And we reported results using area under the curve analysis for our appendix diameter. And then other variables, we used adjusted odds ratios following multiple logistic regression. So in total, we had 934 ultrasounds, which were for suspected appendicitis in the time period. And just for interest, 12,000 children presented to the ED with abdominal pain, and 705 children had an appendicectomy in our centre. What were the outcomes of these ultrasounds? So the vast majority had no appendicectomy at 61%. 1/4 had simple appendicitis, and 1/3 of the appendicitis children had complex disease, with a small proportion of negative appendicectomies. Our median age was 11, majority were female. Negative appendicectomy children were significantly more likely to be girls, with 92% of their population being female. Complex appendicitis children were significantly younger, with 1/4 less than 6 years old. Overall, our appendix visualization rate on ultrasound was 61%, with 62% having a conclusive report, which meant that the appendix was seen and normal, seen and consistent with appendicitis, or another diagnosis. And in the no appendicectomy group, about 1/3 had another pathology diagnosed on ultrasound. This included mesenteric adenitis, amongst others. Overall, the accuracy of ultrasound was 89%, and we had a high specificity of 92, consistent with the literature. So what were the sonographic features which suggested appendicitis? We had a diameter more than 7 millimeters, an appendicolith, the presence of hyperemia, absent luminal gas, and non-compressibility. There were the secondary features of periappendiceal echogenic fat and focal pain.
1 minute.
Thank you. And as you can see, these are the secondary features which are present when the appendix is not viewed. Signs suggesting complex over simple appendicitis included a diameter more than 10.1 millimeters, an appendicolith, no blind ending, and the presence of periappendiceal fluid. These are all in multiple logistic regression. In conclusion, non-diagnostic scans we found were quite frequent at 62%. This is closely linked to appendiceal visualization at 61%. An appendix diameter more than 7 millimeters is more accurate than the current value which we use of 6 millimeters. However, 6 millimeters is found to be much more sensitive, so this would avoid false negatives. We found that a diameter more than 10.1 millimeters, an appendicolith and periappendiceal fluid could suggest complex disease over simple appendicitis. And it remains that clinician gestalt is a significant contributor in the decision for surgery, because we had frequent non-diagnostic scans. Thank you for listening.
Okay, thank you so much for that presentation. I will ask my colleagues if you've got any questions about appendicitis.
Thanks very much, Lauren. Did you look at all in terms of modelling the diagnostic performance of the ultrasound versus other things, as in Alvarado score, so a clinical sort of assessment score for appendicitis, or white cell count, CRP, any other kind of investigations?
Unfortunately, we didn't look at clinical presentation as it was a retrospective study. We didn't want to sort of assume the lack of certain clinical variables as part of the Alvarado score. However, we did collect information about blood tests. We found that CRP was a significant predictor of complex appendicitis, whereas the others were not found to be sensitive or specific enough.
Thank you.
Thanks for that. Damian?
Thanks, Lauren. That was a lot of records to go through there. Just wondering, do you know what proportion of the patients that had a non-conclusive ultrasound went on to have an appendicectomy, and out of those, how many were positive?
We do. So we split the non-diagnostic scans into those which showed secondary signs and those which didn't show secondary signs. We found that those which didn't had a low appendicitis rate of about 9%. However, the ones which had secondary signs present had a higher rate, almost 20%. However, it was sort of specific to what the secondary sign was. For example, if it was free fluid, it depended if it was complex fluid or simple fluid, because as we know, simple fluid can be physiological.
Thank you.
Sorry, one other question. Did you look at it by age at all? As in, was the ultrasound have a much higher appendix detection rate in sort of a 7 to 10-year-old type group than it does in, say, 12 to 16 or 12 to 18?
We actually didn't specify our analysis by age. However, we found that the children who had negative appendicectomy were actually of no different ages to those who had appendicitis or not appendicitis, which we found quite interesting.
Thanks.
Okay, Lauren, thanks for your presentation. That was really interesting. We'll move on to our next presenter, Mark Chia.
Hello.
Are you there? Mark?
Yes, I am.
Do you want to share your screen? We'll see if you can see it, and then you can make a start.
Oh, yes, in a second. Oops.
And I can't see your presentation at the moment. Oh, that's better.
Can you see it?
Yeah, that's fine. Off you go.
All right. So hello, everyone. My name is Mark Chia, and I'm an unaccredited general surgery registrar at Swan Hill District Hospital. And this is my presentation titled Destinations for Emergency Surgical Transfers from a Rural Hospital. Has the coronavirus pandemic had an impact? For some context, Swan Hill District Hospital is a rural hospital located about 338 kilometers from Melbourne. We service a catchment population of approximately 35,000 people in a 100-kilometer radius. This includes some of the southwestern New South Wales border communities that cross the border to be treated at Swan Hill. Our next largest regional referral centre is Bendigo Hospital, which is a 2-hour drive away. Echuca and Mildura are smaller regional towns on either side of Swan Hill. This study was done to better understand where rural surgical patients get transferred to and why, and if the coronavirus pandemic has had an impact on patient transfers. This is a retrospective study of 803 surgical patient transfers from Swan Hill Hospital from January 2018 to December 2020. This chart demonstrates the receiving hospital intake for 770 surgical patient transfers with eligible, accessible medical records. As you can see in blue, Bendigo public and private hospitals combined absorb more than 2/3 of surgical patient transfers from Swan Hill, but a quarter of patients get sent to tertiary metropolitan centers, which I'll elaborate on in the next slide. Smaller numbers of patients get sent to peripheral tertiary or other regional hospitals and private metropolitan hospitals. This flowchart demonstrates the receiving hospital destinations for 770 surgical patient transfers. Again, Bendigo public and private hospitals account for more than 2/3 of surgical patient transfers. About a quarter of patients go to metropolitan Melbourne. This includes St. Vincent's Hospital in Melbourne, which is the tertiary referral center for Swan Hill. Trauma patients get sent to the Alfred and the Royal Melbourne Hospitals. Pediatric patients to the Royal Children's Hospital. Patients with spinal injuries to the Austin Hospital. And smaller proportions of patients get transferred to private metropolitan hospitals and other peripheral hospitals and regional health services. This chart demonstrates the numbers of transfers to Bendigo hospitals versus metropolitan Melbourne versus other regional areas over the years. As you can see in orange, the number of transfers to Bendigo hospitals has remained relatively steady over the 3-year study, especially during the COVID-19 pandemic that really impacted in 2020. However, in the blue line, the number of transfers to metropolitan Melbourne has been decreasing, especially during the COVID-19 pandemic in 2020. Overall, in 2020, there were 9.1% fewer patient transfers out of Swan Hill as compared to the average of 2018 and 2019. And the drop in number of patients in 2020 was predominantly due to the decreased number of transfers from the acute hospital wards. These were non-urgent surgical transfers that still required an inpatient admission. For example, patients with peripheral vascular disease requiring a vascular admission for an angiogram, angioplasty, or management of diabetic foot wounds. The number of transfers, however, from the emergency department has remained relatively steady over the last 3 years. This chart demonstrates patient transfers by surgical specialty. As you can see, orthopedics in blue, general surgery in orange, urology in gray, and plastic surgery in yellow constitute the bulk of patients requiring transfer from Swan Hill for surgical management. Now, given rural hospitals only have limited resources, if we were to reduce the number of surgical patient transfers and thereby boost capacity at rural hospitals, we should target these 4 main surgical specialties as they are ultimately responsible for the greatest proportions of patients requiring transfer out for surgical management and input. This chart demonstrates surgical specialty transfers over the years. As you can see, orthopedics in blue, general surgery in orange, and urology in gray, patients requiring transfer under these 3 specialties have remained consistently high over the last 3 years. Now, these 3 specialties are available at Bendigo Hospital with 24/7 emergency cover. However, the other specialties have either variable availability or no availability at Bendigo Hospital and have to be transferred to tertiary metropolitan centers for management. Finally, this chart demonstrates the primary reason necessitating transfer. As you can see in blue, more than 3/4 of patients that get transferred out of Swan Hill are transferred because they lack the appropriate specialty surgical input and management locally. 12.3% are transferred because they lack the appropriate ancillary services such as an ICU, a pediatric anesthetist, or an MRI machine. 8.6% are transferred out because of their high anesthetic risk. They are either too comorbid, too advanced in age, or have BMI that's over the limit to be safely managed at Swan Hill. This chart is important as it tells us that if we were able to provide the appropriate specialty surgical input and management locally, more than 3/4 of patients, thank you, more than 3/4 of patients that are currently being transferred out could actually be then managed locally. In conclusion, in this 3-year study of surgical patient transfers from Swan Hill, approximately 5 patients were transferred out of hospital every week. The COVID-19 pandemic seems to have affected transfer destinations, given that the transfers to the nearest regional health service, Bendigo, has remained the same. However, the metropolitan transfer numbers have decreased. The pandemic has highlighted the importance of being able to treat patients locally, as close to home as possible. And understanding the reasons for transfer may provide a basis to make recommendations for improved emergency surgical healthcare delivery in rural settings, as well as to build future capacity at rural centers. Thank you.
Thanks very much, Mark. That's a really interesting study. I'll hand over to my colleagues for any questions. Daniel, Damian.
Yeah, thanks very much. I agree. That's really quite interesting to look at. Clearly, Bendigo does a lot of heavy lifting.
Oh yeah, it does a lot.
Yeah.
Constantly cool.
So yeah, fascinating. Out of curiosity, did you do a month-by-month analysis? Because it'd be quite interesting to see whether the periods of high outbreak within Melbourne correlated to sort of dips in transfer to Melbourne or not.
I understand what you're asking. No, we did it by the years because I'm kind of by myself in Swan Hill. I've got one other resident with me, so it's a bit tight on manpower. But yeah, that'd be interesting if I had more people. We can do it month by month.
Yeah, no, very, very interesting. It's kind of beautiful in its simplicity and very topical. So well done. I think it's really good.
Thank you.
Thanks for that one. Damian, any comments or questions?
Yeah, I guess it's a little bit similar to what Dan has asked. I mean, there's a lot of factors that influence transfer rate, and seeing if it directly correlates to when there were COVID outbreaks and lockdowns in metropolitan Melbourne would be interesting, because I may have missed it, but is the reduction in transfers all directly due to COVID, or was there a reduction in presentations to the hospital in the first place? Because the transfers to Bendigo remained fairly steady.
Yes, and the ED transfers remain relatively steady.
Yeah.
So I'm not sure actually. We didn't go into that in the study, but the thinking is that because of the restrictions and sending people to St. Vincent's, which at that time were accepting or were full of COVID patients in ICU, the nursing supervisors and bed managers were saying, hey, if you can, don't send them here. Or patients that would routinely be transferred as inpatients were being managed in the outpatient setting, by the vascular team, for example. So yeah, it'll be an interesting next part of the study to do.
Yeah, I think it would be important to take what you started and build on it, because I think it would be interesting to see the true impact that the pandemic has had.
Yes, I'm here for another 3 months, so I'll work on it.
Okay, thanks, Mark.
Thank you, everyone.
Very, very topical and really interesting. Thanks for that.
Thank you.
We'll move on to our next presenter, if that's all right. Taha Mola.
Yes, how are you all? Thanks for having me.
There we go. Yep. So you want to share your screen, and then we'll see if you're ready to go.
Is that working?
Yep, we can see that. So whenever you're ready.
Okay. So I guess we have a question. Have we lost patients with ureteric stones? I'm sure that's not a question that keeps many of us up at night, but today I want to tell you about why it's such an important question. Worldwide, about 12% of people are going to develop a kidney stone at some point in their lives. To put that into context, that means that potentially one of the 11 presenters in today's session has the chance of developing a stone, and hopefully that's not me. And although these stones themselves can be very small, they have a very large financial impact. Although there was no Australian study to give us information, one US study did suggest that the annual healthcare expenditure for these stones was $750 million US. That would be the same as building 2 MCGs every single year. So with that knowledge in mind, when my supervisor, Mr. Dan Lenigan of St. Vincent's Urology, and myself, Dr. Taha Mola, came across this graph in the Australian literature, we were a bit taken aback. This little green line is showing that the number of scope procedures that we are doing for kidney stones, which is the most common type of procedure that we do, has increased in Australia by 3 times. So we decided to do a literature review because maybe the incidence of stones had gone up to explain this result. But alas, it's something that hadn't been studied for over 20 years. So that's when Dan turns to me and he asks, Taha, do you think we've lost patients with ureteric stones? And by that, he meant 2 very specific questions. 1, Has the prevalence of stone burden in the population truly increased? In this case, specifically ureteric stones, or is the proportion of operative procedures that we're doing increasing instead? To answer these two questions, we utilized two different databases. The first was from the Australian Institute of Health and Welfare, and the second from the Medicare Benefit Schedule. We collected all public and private operating data for ureteric stones, as well as all hospital admissions in Australia for ureteric stones. And I'll tell you our most fascinating findings. So in 2001, there were about 86 diagnoses of ureteric stones here in Australia per 100,000 population. That increased slightly in 2009, reaching 104 cases, before seeing a massive explosion, reaching a peak in 2017 of 170 cases per 100,000 population. That is almost a doubling. That means that instead of one person in today's presentation potentially developing a stone, there might be two. Looking at interventions, in 2001, there were about 34 procedures per 100,000 population. That again was stable until 2009, before again seeing a massive increase, reaching a peak of about 64 procedures per 100,000 population. This was driven largely by the public sector, and our thinking is that this may be due to better emergency department access, particularly as diagnoses were increasing over the same time period. These two graphs don't tell us the full story, however. When we look at how diagnoses and interventions have actually changed or grown since 2000, we can see that whilst diagnoses have gone up, interventions have gone up at a very similar rate. It's been proportional. I'll draw your attention to this little gray line, which is telling us how many stones do we do a procedure on in Australia. The answer is about 56%, and that's been remarkably stable for 19 years. So to answer those two questions, has stone burden increased? Well, it has. But has the proportion of intervention increased? It hasn't. It's been proportional. So then that begs the question, why has incidence increased? Well, I'll tell you some of our hypotheses. The first one is related to age. In Australia, over the last 20 years, the proportion of Australians over the age of 65, including those over the age of 85 as well, have increased in Australia by almost 4%. That seems like a small number, but that actually accounts for an extra 1.8 million Australians at risk. When we broke down our data, we could see that the populations that have had the biggest growth in terms of diagnoses is this over 65-year-old age group. As well as that, the age group with the greatest growth in interventions is also this over 65-year-old age group. And as well as that, when we looked at obesity in Australia over the last 25 years or so, the proportion of adult Australians, including those over the age of 65, who are now considered overweight or obese, has increased in Australia by about 10%. Again, a small number, but over 25 years, that's an extra 6 million people at risk. And this is important because we know that obesity and age both increase the risk of stones. And it's important to mention as well, you know, that stones themselves are more prevalent in the westernized nations.
One minute.
By things like the westernized diet, thank you, which is characterized by high saturated fat intake, low fiber intake, as well as changes in how Australians hydrate. And these are all risk factors for stone as well. So what conclusions can we draw? Well, we've seen that the number of stones as well as the number of interventions have gone up, but it's proportional. There have been significant changes in the age demographic, and importantly, something our study has highlighted. This is a topic that hadn't been studied for 20 years, and we've shown the importance of keeping epidemiological information such as this contemporary, because it has implications for informing public health practice. So to answer that question, have we lost patients with ureteric stones? Are we operating more than we should be? No, because it's been proportional. But there still is more to research, including looking at how we treat stones conservatively here in Australia, as well as trying to identify other causes to explain this rising incidence in Australia. Thank you very much.
Thank you for that. That was a really interesting idea you're putting forward. Taha, have you got questions, Daniel and Damian?
Yeah, that was a really good study and really nice presentation. So thank you for that. I suppose my question is not directly related to your study. It sort of isn't. It's very impressive to get all of that MBS data and hospital billing private v public breakdown done. How did you manage to actually achieve that?
So these are actually publicly available databases. The actual extraction of the data is what's difficult about it, because it's released in a very raw format. So we had the help of some statisticians, as well as a lot of time commitment from my end to collect the data, but it's publicly available data sets, and it just needs some expertise in being able to break it down to look specifically at what you want to research.
Yeah, there you go. Thank you.
Damian?
Well, thanks, Taha. I don't know if you can answer this question, but it's a two-part question. Firstly, why do you think the prevalence has increased so much? Is it a matter of true increased incidence, or is it just a matter of increased detection and presentation? And secondly, once you realized the prevalence had increased so much, did you expect that the proportion requiring procedural intervention would increase? Or did the fact that it remained steady surprise you?
Excellent question. Thank you very much. To answer that first question, and it's an excellent suggestion. So we actually did try to look at the rates of CT scan of computer tomography that have been done in Australia, specific for the kidneys and the urinary tract. And whilst we found that had certainly increased, one, it was difficult to correlate that data specific to the number of diagnoses of stones, but also interestingly, we didn't see the same level of increase in CT scans being done. We couldn't look at ultrasounds, but the less increase in CT scans compared to the increase in prevalence. So that was something that was interesting. In relation to the second question, why has prevalence gone up? Well, sorry, can you repeat the second question for me again?
Did it surprise you that the proportion didn't increase? Because unless the disease became more complex, I would have expected that the proportion would have stayed the same.
It did surprise us, actually. There was two real main reasons for that. Number one was because we've seen these are relatively recent studies, the ones that I had shown at the start of the presentation, which had shown that the endoscopic procedures had increased so dramatically in Australia. And we didn't think that the prevalence had increased at the same rate. So that was our initial suspicion. But the second thing as well is that our study has also shown, or I should say suggested, that the size and the symptoms of stones in Australia currently are becoming larger and more symptomatic. And the reason that we know that is because the way that these stones are coded is based on the International Classification of Disease. And some of these classifications break down stones by presence of complications, including things like hydronephrosis, where they're stuck in the urinary tract. And there certainly have been features to suggest that stones are becoming larger in Australia, and that the conservative treatment in Australia has gone down. So those were two factors that we thought would suggest that operative intervention had gone up out of proportion. So we were a little bit surprised. But that's a good thing. It was a good surprise.
Thanks, Taha.
That's great.
Thank you.
Thanks again, Taha, for your study. Really interesting study. The next presenter on our list tonight is King Tung Chung. Are you there?
Yep. Hello. Hi. How are you?
Welcome. If you're ready to go, do you want to share your screen?
Yep.
So we can see it. Yep, that looks good. So whenever you're ready, you can make a start.
No worries. Thank you very much. So thank you to the organizing committee for letting me speak today. I'm Kelvin, one of the unaccredited registrar at Eastern Health. So today I'm going to talk about elective lab colleague as an entrustable professional activity for general surgical trainees in Australia. As we all know, surgical training is challenging. It is challenging in that we need to ensure the procedural competency of surgical trainees while making sure the safety of the patient. Now, Rex has outlined 10 essential competencies to guide training in surgery. This traditional model, however, often assesses competencies in isolation and over a wide spectrum. Entrustable professional activities, or EPAs, on the other hand, measures specific observable units of work at a particular level of training. It is a learner-centered tool that assesses competencies in integration. Implementation of EPAs is, of course, challenging because it must be tailor-made to a specific level of training, and it must be a procedure that can be performed safely and frequently enough by surgical trainees. Now, elective lab colleague is one of the most common procedures performed in general surgery. We therefore aim to evaluate the operation time and surgical outcomes of elective lab chole and to establish it as an EPA for our surgical trainees. All elective lab chole over the 18-month period at Eastern Health were included. Primary operator was defined as the first name documented in the surgeon section and was classified into set trainees, fellows, and consultants. Now, there were a total of 592 patients over the study period, with an average age of 53 years old. Set trainees are primary operators in about 46% of all the cases. This slide shows the average operation time in different groups. And you can see that on the far right, Set 2 trainees actually take longer compared to their more senior colleagues, as expected, with an average operation time of just over 2 hours. The average operation time plateaued at around 80 minutes from Set 3, and there were no differences between Set 3 trainees onward. It therefore appeared that elective lab chole has a steep but relatively short learning curve at the early stage of Set training. Now, what about the safety of the procedures? Well, complication rate was similar between Set trainees and consultants. No differences were seen between different Set levels either. It was worth mentioning that although not statistically significant, all cases with bowel leak were performed by consultants, with a bowel leak rate of about 1.2% in this group. Now, we think this is due to the fact that consultants are more likely to take charge in difficult cases. It is in line with a finding that registrars are more likely to operate on female patients, in whom lab chole are traditionally deemed to be easier due to intra-abdominal fat distributions. Readmission and return to theatre rates are also comparable between groups. Elective lab chole is therefore a safe procedure for Set trainees to perform. Now, it is also worth noting that all conversions to open were performed by consultants with an overall rate of 3.7% in this group. Now, open cholecystectomy has become rare in a general surgery setting. Cases requiring conversion to open are often difficult, and consultants are likely required to perform the procedure due to the lack of experience of Set trainees. We therefore encourage Set trainees to participate in cases where conversion to open is performed, and that can build into our EPA assessment model as well. So you may ask, what would an EPA form look like? This is a sample template of how the assessment form will look like. We have created 4 different grades at Eastern Health according to the expected level of skills acquired by the Set trainees. Moving up each level represents progressive acquisition of skills to perform more complicated operations independently. So what are the real-life implications? Well, elective lab chole as an EPA provides timely feedback for Set trainees. It also set a shared benchmark for consultants to assess and guide trainees. More importantly, it could improve the efficiency of elective surgery list planning, perhaps by setting aside more time to ensure sufficient learning experience, avoiding cancellation and overbooking. But of course, it must be balanced between list efficiency and safety of patients. Now, there are, however, some limitations to our study. Firstly, it is a retrospective study, and we weren't able to distinguish the contribution of the assistant on the overall operation time and surgical applications. One interesting finding is that consultants actually take longer to complete operation when assisted by a Set trainee when compared to an accredited registrar.
One minute.
Thank you. Is that the extra time taken may represent some formal teaching undertaken for the Set trainees. Secondly, despite the large sample of patients, the study is underpowered to detect significant differences in complication rates due to the rare nature of occurrence. So, what can we draw from that? Well, in summary, elective lab chole has a steep, relatively short learning curve at the early stage of Set training. Although junior Set trainees took longer to perform the procedure, it can be safely performed by surgical trainees at all Set levels when under appropriate supervisions. So therefore, we think that it could be used as an EPA tool for assessing the competency of early Set trainees. Finally, I would like to acknowledge the many others who have contributed to this project. And this is the end of my presentation, and I'm happy to answer any questions. Thank you.
Thank you very much for that. I'm sure my colleagues might have some questions.
I'm conscious of the fact that I keep hogging pole position. So Damien, do you want to go first? I feel like I might keep asking all of the easy questions to answer.
No, you go first. You go first.
Yeah, thanks very much for that talk. I suppose in some ways it's more of a comment than a question, but there's a fairly obvious source of bias in the primary operator. So I think you need to be a little bit careful about the conclusion that the learning curve for a lap collie is short, because the fact that you've demonstrated that the consultant sort of operating time is still fairly long, and that it's actually longer with a more senior assistant, might just be demonstrating the increased complexity of the cases. So the longer operating time with a set registrar being the assistant rather than the unaccredited registrar might be representative of the fact that the set registrar was assisting because the operation was complex, as opposed to them having the opportunity to be the primary surgeon. So in terms of the specific question of your study in regards to the development of an EPA, I think that's all quite accurate, but I think it's just a case of being a little bit careful about some of the other conclusions. The fact that all the conversions to open, all the bile leaks had a consultant name attached, it sort of demonstrates that there's a fairly significant bias in who's labeled as the primary surgeon. And, those operation reports, it's not uncommon when things start going bad to say, oh, look, put my name first. Or conversely, if you're the registrar and you're worried about being taken down in the audit meeting, you might make sure it's not your name first when you write the operation report. So, so there's a lot of little factors to consider. So I think in regards to your overall question, I think it's a really good study design and things. I think you just need to be a little bit careful about some of the other sub-conclusions along the way. I'm sorry, that was a comment rather than a question, really.
Yeah, no, thank you for the comment. And actually, we in our manuscript we have emphasized the fact that there's a selection bias, like you said. If it's a more difficult procedures, and sometimes the set trainees would prefer having the consultant as the first operator, and that's why in the method section we could only specify that we define the primary operator as the first name appeared, but we couldn't kind of distinguish the contribution between the assistant and the consultants. Yeah. So thank you. Thanks for that.
Okay. Thanks for that. Damien, you have any questions?
Well, firstly, to follow on from what Dan has said, I think it'd be important to take into account those sort of potential biases when sort of formulating your conclusions in terms of the learning curve. And secondly, lap collie is going to be an EPA for the GSET program. So how does your template or your proposed template compare to the assessment that's in place for the new program?
It's so with the kind of EPAs coming along, I guess the template itself it has to be kind of consistent with the new kind of program template. I guess the study is more kind of emphasizing the fact that it would be a appropriate procedure to perform for junior, kind of especially in the set junior levels. But yeah, no, I agree that our template is basically kind of it's a mirror of what the template is in place at the moment.
Thank you.
Okay, thanks very much for that interesting presentation. We'll move along to our next presenter, who is Ruchira Nandekar. Ruchira, are you there?
Yes, I am. Is that all good?
Yeah, we can see that. That's perfect. Whenever you're ready, you can make a start.
Thanks very much, Matthew. Hi, everyone. My name is Ruchira, and welcome to our talk on development and validation of a method for detection of circulating tumour cells in muscle-invasive bladder cancer. So bladder cancer is the 11th most common malignancy in Australia, but it's also Australia's only cancer with a negative trend in survival, making it the centre of a lot of research. Now, 90% of bladder cancers are urothelial carcinomas, which arise from the epithelium or the urothelium of the bladder. And these urothelial carcinomas can be divided into two categories based on the degree of invasion. So non-muscle invasive bladder cancers are contained within the urothelium and underlying lamina propria, and these are more common but usually benign. And then we have muscle-invasive bladder cancers, or MIBC, and these invade into the detrusor muscle and can progress to metastatic disease. Now, they're less common, but usually have poorer outcomes. Now, 2/3 of patients diagnosed with muscle-invasive bladder cancer don't survive beyond 48 months despite receiving curative treatment. And this in part is related to how complex tailoring treatment is. For example, the benefit derived from chemo treatment can't be predicted ahead of administration. So while some patients may endure the toxicity and side effects only to result in unsuccess, others may experience downstaging of disease and cystectomy may be avoidable for them. In such cases, it would be useful to know what the true disease burden in a patient was at any given time to guide clinical decision-making. In these scenarios, circulating tumor DNA might be our answer. So this is essentially DNA released from tumor cells into the bloodstream after apoptosis or necrosis, and we can detect it with a liquid biopsy of the blood or urine. Now, there are several advantages to detecting ctDNA. Firstly, it uses liquid biopsies, which are non-invasive, so we can afford to easily and repeatedly obtain samples with minimal risk to the patient. Secondly, because the half-life is on average less than 2 hours, it provides almost real-time monitoring of tumor load. Further still, in MIBC, detecting ctDNA can help with surveillance by identifying the presence of residual or recurrent disease after cystectomy with a lead time to an imaging diagnosis. It can help with justifying adjuvant chemo in those who are more likely to benefit, and help with avoiding cystectomy after neoadjuvant chemo if a patient's ctDNA levels are very low or zero. Now, in order to detect ctDNA, we extract DNA from a blood sample and then try to find the presence of mutations in it to distinguish it from other normal DNA in the blood. Now, to do this, we usually rely on next-gen sequencing, but this is time-consuming, expensive, has a low sensitivity, and it produces a lot of data. An alternative, droplet digital PCR, is quicker, cheaper, and highly sensitive. The only caveat being that, unlike next-gen sequencing, you have to know which mutations you're looking for before you actually begin. So our aim for this study was to develop a reliable method for detecting ctDNA in MIBC using droplet digital PCR. To begin with, we first had to identify which mutations we thought would be highly prevalent in MIBC tumours. Now, our goal was to pick up a large proportion of affected patients with the fewest number of mutations. So what we needed to find were common mutations in bladder cancer. And sometimes when papers refer to common mutations or commonly mutated genes, it can be easy to get confused between the two. So here's an example of both. The type of diagram you're looking at here is called a lollipop plot, and the grey bars here are complementary DNA. Each lollipop represents a mutation, and just disregard the colours. The x-axis shows the nucleotide number at which each mutation occurs, and the y-axis shows the frequency of the mutation. As we can see here, ARID1A seems to be prone to several mutations all along the length of the gene, but nearly all of which have only been picked up around once, and therefore are not commonly occurring. Hence, ARID1A is a commonly mutated gene, but doesn't have any common mutations. In contrast, this diagram clearly shows that one specific mutation is a very common one to acquire. So if a patient were to have an FGFR3 mutation, more likely than not, it would be this one. Hence, FGFR3 possesses a common mutation. If we want to minimize the number of mutations we're screening for, we want to search for mutations like that in FGFR3, which we know will commonly occur in a bladder cancer patient, as opposed to looking for something in ARID1A, which we know will likely be mutated, but we won't be sure exactly whereabouts. So ultimately, we selected the top 10 most frequently occurring mutations seen in MIBC as per the data in the Cancer Genome Atlas, or the TCGA. These mutations are shown along the x-axis of these graphs, with the most common mutation on the left to the 10th most common on the right. The left-hand graph reflects the percentage of MIBC samples in the TCGA database that were positive for each of these mutations. So for example, the most commonly seen mutation occurred in 12.4% of TCGA samples.
1 minute.
Right, thanks very much. The right-hand side graph depicts a line to illustrate the cumulative effect of adding each of these mutations to a gene panel. So as we continue to add more mutations, the percentage of samples we can pick up with the gene panel increases. So theoretically, adding all 10 to a gene panel would result in 40.8% of samples having at least one of these mutations, and thereby 40.8% of MIBC patients would be picked up on a blood test. So with this expectation in mind, we designed a gene panel containing all these 10 mutations and then ran retrospectively collected MIBC tissue samples on it to test if the assay could correctly detect at least 40% as having MIBC. At the end of our study, we had assayed 77 tissue samples, of which 76 had at least one of the mutations in the panel, meaning our ddPCR test had a 98.7% detection rate, far higher than the predicted rate based on the TCGA, which used next-gen sequencing. Given the successful outcome of this study, we've now commenced prospective collection of urine, blood, and matched tissue to observe if the same level of efficacy can be achieved with circulating tumour DNA. Thank you very much.
And thank you for that, Chia. Damian, you want to go first?
Yeah, I'll go first this time. Thanks, Chia. Can you expand on the utility of these DNA markers in practical terms? Is it purely for detection of disease? And if so, what advantage do they have over already established methods?
Right. So whilst a few of the mutations that we've selected happen to have additional predictive or prognostic benefit, for example, we've done this same gene panel study for non-muscle invasive bladder cancer, including ERCC2 mutations, which have shown to have be predictive for cisplatin sensitivity. That's not the aim of this study. It's mainly for detection of recurrent and residual disease, and also to monitor tumor burden so as to help in administration of chemotherapy. So whether or not someone should receive adjuvant chemo if they've got substantially eliminated disease, or alternatively avoid cystectomy in those who might have very diminished disease after neoadjuvant chemo. There is, for example, some people do question whether or not there's any diagnostic potential, but what happens is a lot of these mutations can also be present in other sorts of cancers. So if someone's already diagnosed with bladder cancer, it makes us more confident when saying that the mutational presence is related to bladder cancer specifically.
So practically, can it be currently be incorporated into existing surveillance processes?
Yes, it should be very simple because of the use of liquid biopsy. Standard blood tests that are taken at the time of any clinical milestone, so for example, at the time of procedures, at the start and end of any chemo or BCG treatment, is very ideal and very quick turnover. Takes about a day or two just to get the full results.
And how much does it cost in that case?
Right now, we're doing it as a research measure, so no cost, but ideally it would be as part of it should be covered for the patient, I believe. But yeah, to be seen.
Thanks. Daniel?
Yeah, Damian partly asked one of my questions there, which was if you're going to suggest such frequent use of it, then what's the cost of that? Because I believe those gene panels are all pretty exy. And then the other part of the question was somewhat related to what you were just expanding on, in that does the ctDNA have a correlation with stage of disease? As in, if you've got a really early T1N0 cancer, do you expect the ctDNA to be present or not? Is it more likely to correlate with, disease staging T2, T3, T4? And if so, can you, if it does correlate to T stage, can you then draw as significant a conclusion as you're initially alluding to in saying whether or not a patient needs to go for completion cystectomy or, receive adjuvant therapy, if there may be a really small focus of tumor remnant?
Yeah, that's a really great question. Right now, all the literature says that the amount of ctDNA in the blood is more indicative of the presence of cancer. So there's a small threshold at which it has to be above to be sort of an indicator of recurrence of cancer or presence of cancer. At the moment, I am in the process of extracting DNA from urine and blood samples that we've taken prospectively. So once that is accomplished, I believe I'll be better placed to really talk about if we like the level of ctDNA in comparison to the patients that we had with NMIBC versus MIBC, and then accordingly the stages of cancer that they were at. So unfortunately can't answer that just yet. But in the tissue, it's definitely the same. Yeah.
Okay, that's great. Thank you again for that. That was really interesting.
Thank you very much.
Thanks. We'll now move on to Frances Harley. Frances, are you here?
Yep.
I can see you. Let's see if we can see your presentation.
Mm-hmm.
That's looking good. Yep, that's good. I can see that. Whenever
Lovely.
you're ready.
Good evening, and thank you for the opportunity to speak tonight. We're discussing our experience of does multidisciplinary care change uro-oncology treatment plans in regional Australia. So 7 million Australians live in regional or rural areas. Of the 150,000 people annually diagnosed with cancer, 30% live in regional areas, some distance from major tertiary care centres. Those that live the furthest from large treatment centres are at the highest risk of poor outcomes. 25,000 people will be diagnosed with a genitourinary malignancy in 2021. The 5-year survival rate is approximately 82% for these cancers, ranging from 55% for bladder cancer and up to 97% for testicular cancer. Multidisciplinary care is considered best practice in the treatment planning and care for patients with cancer. It is an integrated team approach that incorporates medical and allied health professionals to deliver individualized care treatment plans and consensus with the patient. Joining the efforts from different professionals is thought to improve patient management, in contrast with the old idea of a global treatment offered by a single physician. In regional areas, this approach is even more complex, with the incorporation of technology to span location differences between specialists. In addition, the inclusion of general practitioners, practice nurses, and specialist nurses, such as prostate and breast, allows for a greater continuity of care beyond the traditional meeting, as patients' history and psychosocial issues are more comprehensively addressed. The study aims to analyse the impact of MDC by assessing how proposed treatment plans change following their discussion at a multidisciplinary meeting. Patients were presented by urologists at a regional uro-oncology multidisciplinary meeting over a 12-week period were prospectively identified. Treatment plans were compared before and after the meeting. Primary outcome was the proportion of patients with a major change in a plan. Major change was identified as a newly selecting a pathway of either imaging, biopsy, surgery, radiotherapy, other local therapy, systemic therapy, or surveillance, as opposed to modifying a treatment within a given pathway. 86 patients were enrolled, 94% were men. Median age was 70, with a range of 25 to 86. Looking at the cancer streams, prostate cancer was the largest and included 72% of the patients. Renal was 18%, 4.5% for testis and urothelial cancer, and one patient had a synchronous TCC in prostate. Looking at the prostate cancer stream alone, when you assess their grade groups, demonstrated equal numbers across grade groups 1 to 3, and the high-risk prostate group, composed of 26% in total, also had 2 patients presenting with metastatic disease. Overall, there were only 8 changes in management plans following MDT presentation. The vast majority, 50%, were for renal tumours, 25% for prostate, and 1 patient each for urothelial cancer and concurrent TCC in prostate. Of the proposed changes, 3 were for partial nephrectomy, 3 for the inclusion of ADT to radiotherapy, 1 for a renal biopsy, and 1 for palliative radiotherapy and immunotherapy in the context of a clinical trial. This study shows majority of treatment plans were not changed at 88% at this regional MDT. The likely reason for this is that the majority of patients discussed were prostate cancer patients. 74% of the prostate stream was low to intermediate risk disease, which have set treatment plans across the international guidelines. So there's very little give or take about how a patient is managed. The changes that were proposed for the prostate stream was the addition of ADT to radiotherapy, which aligns with the findings of made recent studies, which demonstrates an overall increased 10-year survival compared to radiotherapy alone.
1 minute.
Thank you. The renal stream had the most changes, with the outcomes advising active treatment or a tissue diagnosis over surveillance. The likely reason for this direction is that though most small renal masses are benign, 25% are malignant. Though there are no set guidelines, general consensus is that surveillance should only be offered to those who are elderly or not fit for surgery, while general management is for nephron-sparing surgery. One major limitation of the study is that it's a small single service study, so it should be interpreted with caution. It's unknown whether this is truly representative to other regional services outcomes or even those of metropolitan hospitals. Also does not show whether these finalized treatment plans are undertaken by the surgeon or the patient. Multidisciplinary meetings remain gold standard within neuro-oncology, and our experience suggests that they result in a change of treatment plan for a significant minority of patients, coinciding with what you would expect as gold standard care.
Thank you very much for that. I'll go to Damian again first.
Thanks, Francis. Can you comment on whether there was any correlation between the experience of the clinician making the initial decision compared to those patients that did have a change in treatment plan?
Yeah, so we didn't really look at that specifically, but obviously it's a small centre, so only two urologists essentially were presenting their patients, and it's a referral system to oncology, so it's actually not run by the surgeons, the meeting. So each patient is referred by a consultant to the meeting and then discussed amongst the consultants at the meeting, which would include the radiation oncologist and the medical oncologist. So everyone's at least got letters behind their name. Yeah.
Okay, thanks for that. Daniel?
Yeah, thanks very much, Francis. So just to confirm I interpret it correctly, all of the changed management plans were to go to a more aggressive therapy, as in the original plan had been for surveillance and they were upgraded to either surgery or surgery and adjuvant therapies. Is that right?
Yeah, it's particularly for the renal stream. So the four that were changed, one of them was to do a tissue confirmation with the biopsy, but the other three were, instead of for surveillance, for partial nephrectomy. And then, sorry.
Oh no, that's a yeah. So sort of following on from that little section was the driver of the change. Did you look at who drove the change? As in, was it that the radiologist has said this looks more aggressive than what's on the report, and that's caused the same primary clinician to change their mind, or is it that another clinician has said, no, I think you're gun shy, you should go for it?
Yeah, so not going into too much details, one of the surgeons does nephrectomies, one doesn't. And it was during COVID as well. So there had been, and part of the reason the study sort of got started was there'd been a notice that some of the clinicians were thinking we should move away from more active treatments in a general sense across the board. But a lot of the recommendations, particularly because these patients were young and relatively comorbid, was no, actually, we shouldn't be surveilling on these patients, even if we are in a pandemic, or even if the masses are relatively small, they should still actually have treatment that would be considered routine. Yeah.
Thank you.
Thank you.
thanks for that. We will move along to our next presenter, who is Isaac Tay. Isaac, are you there?
Hi, yes.
Hi.
Thank you.
When you want to share your screen?
Yep.
And that's great. We can see that. So whenever you want.
Great. Thanks. Thank you. So good evening, everyone. I'm Isaac Tay. I'm an unaccredited general surgery registrar in Royal Melbourne Hospital. Today, I'll be presenting on the outcomes of damage control surgery with laparostomy in non-trauma patients. I have no disclosures. So the use of damage control surgery, or DCS, is widely established practice in managing critically unwell trauma patients. And this includes using abbreviated surgery, temporary abdominal wall closure, followed by restoration of physiology before definitive management. Over the last 15 years or so, some of these concepts have been slowly incorporated into the management of non-trauma abdominal emergencies, where these patients who are experiencing this severe intra-abdominal sepsis or bleeding are just as susceptible to detrimental effects of acidosis, hypothermia, and coagulopathy. So DCS may be similarly advantageous by interrupting the vicious cycle of this triad. There's a paucity of literature, as previous studies have described DCS in small case series and retrospective cohort studies, which limits applicability of findings. So hence, this study aims to describe the short-term outcomes of patients undergoing DCS and laparostomy for non-trauma abdominal surgical emergencies in a tertiary hospital. This is a single-center study in Royal Melbourne Hospital where all patients who had DCS with midline incision and laparostomy for an abdominal surgical emergency over a 5-year period were included. Patients who had elective surgery, trauma, or had laparostomy performed in another hospital were excluded. Patients were identified from a general surgery database, and their medical records were reviewed retrospectively. So this table describes the baseline characteristics. 80 patients were included in our study. 46% were male, and the median age was 67 years old. In terms of comorbidities, about 20% had ischemic heart disease, 20% has diabetes, and 10% has COPD. And more than a third of patients were on anticoagulation and antiplatelet agents, and close to 20% is on immunosuppressive medication. Here we see the indication for initial surgery, and majority were due to mesenteric ischemia, followed by intra-abdominal sepsis, and then enteric strangulation, hemorrhage, physiologic instability, and bowel obstruction. So the median duration of DCS performed was 78 minutes, of which bowel resection was the most commonly performed intervention at around 70%, and then 50% had washout, 10% had hemostasis. This next pie chart shows the reasons why the abdomen were kept open at the end of the case, and most were due to ongoing concerns for further mesenteric ischemia, followed by intra-abdominal sepsis, physiologic instability, and then hemorrhage. This next table describes the outcomes. So 6 patients died prior to relook surgery, and 74 patients had returned to theatre. And during the subsequent surgery, further 4% had unsurvivable injuries, and close to 80% of patients needed further intervention. The median length of stay in ICU was 4 days and 19 days in hospital. In terms of discharge, so 53% of patients were discharged home and 30% went to rehab. The overall mortality was 25%. This graph illustrates the number of relook surgeries, and most patients had 1 return to theatre, and it ranges from 0 to 4. This graph looks at the type of intervention performed during relook surgery. So 31% needed further bowel resection, 32% had an anastomosis, 38% had a stoma, and 12% and 8% needed further hemostasis and washout respectively. So our institution has adopted the use of laparostomy, largely based on our trauma experience. During the few episodes of return to theatre, majority, which is 80% of patients, required some form of further intervention, which supports the use of laparostomy. And this includes forming a bowel anastomosis. So if these patients had a 1-stage surgery, a stoma potentially might have been performed instead. The mortality rate is low at 25% when compared to 37% reported by Girat et al., with the largest case series looking at non-trauma DCS and laparostomy. And it's also comparable to the mortality reported in literature for trauma cases. Also, more than 50% of patients were able to be discharged straight home from hospital. The major limitations here are that it's a single center retrospective non-comparative study, and we're currently working on the next part of this study where we are comparing to similarly matched patients with abdominal thanks. With abdominal surgical emergencies who were operated on and closed. So in conclusion, the most common indication for surgery and laparostomy was mesenteric ischemia. And the benefit in the use of laparostomy lies in its rapid completion of operation, where there's avoidance in forming anastomosis and stoma. And then there's a quick closure method that minimizes damage to the fascia. It also facilitates reloop surgery and interventions as required. And therefore, based on our experience, DCS and laparostomy has a role in the emergency abdominal surgery armamentarium. So I'd like to acknowledge my senior author and supervisor, and as well as Department of Surgery in Royal Melbourne Hospital. Thank you.
Thanks very much, Isaac. Let's have a couple of questions. Damian, what do you think?
Thanks, Isaac. Yeah, I think that future direction that you're looking at, comparing to patients who didn't have laparostomy, who perhaps should have had one. But can you comment on patients who did have a laparostomy where perhaps it wasn't required?
Yes. So in our data, that would translate to about 20% who didn't have any further procedure done when they went to have a relook. So I guess it's never 100%, 0% thing. So we can say that 80% of patients actually it was the right decision to form a laparostomy so that we could go back in and have a reassessment for further ischemia or bleeding. And there was actually a lot of intervention that was performed. So with every, I guess, algorithm and treatment, there will be some patients with like a false negative per se. Yeah.
Can you extrapolate from the results that you've obtained to further streamline the algorithm so that to reduce the number of patients that have, I guess, an unnecessary laparostomy, because laparostomies are resource intensive?
Yeah, thanks. So we hope to compare these factors and streamline and find factors which affect the yield of laparostomy in the further surgery. So we could be looking at the degree of physiologic instability or coagulopathy or the findings, and such as a certain indication such as ischemia or bleeding might have a higher weightage for needing interventions further on. But we haven't looked at this during this study, but I think it's a good point to look at, and hopefully with our comparative study, we can find some weighted into the factors that we can find. Thank you.
Daniel, any questions?
Yeah, thanks very much, Isaac. It's kind of quite interesting to see that pancreatitis wasn't sort of much higher up on the list of diagnoses, because I would have thought that would be one of the most common kind of indications. So that was very interesting. I suppose slightly continuing on from Damian's theme, the median length of stay in ICU was really quite short. It was only, I think, 4 days, which if you include the day one being the day that they have the laparostomy performed, and then most of them will return on day 2, the next day or the day after. So that's sort of day 2 and 3 there. And then it seems like after abdominal closure, they were able to rapidly transit from intensive care to the ward. Were you surprised to see that such a short length of stay in ICU? Did that indicate that the laparostomy facilitated rapid correction of physiologic derangement, or did it indicate that perhaps they were, actually a little bit better off than first thought and could have proceeded to their definitive surgery initially and therefore actually kind of stayed in ICU longer potentially?
Yeah, thanks, Dan. I guess looking at the data as a whole, this is a median figure. So I do see patients who stay like 2 weeks, 20, 30 days. So I'll guess like those group of patients would benefit from DCS. And also the point of DCS is to reduce the amplification of risk and to correct physiology. So if DCS can have that effect in reducing the length of stay, then I would say that that's achieving the target. But I see what you're saying with some of these patients. It could have been in a situation where DCS wasn't needed, and hence it's reflected by a short length of stay. But as a whole, I would say that it does have its benefit.
Okay, thanks very much, Isaac.
Thank you.
Thanks for the presentation.
Thank you.
And we will, you stop sharing that. You can. That's great. Thanks. And we will move along to the next presenter. John, are you there?
Yep, right here.
John.
I'll start sharing.
Yeah, there we go. Whenever
Everyone able to see that okay?
Yeah, it's good.
Fantastic. Okay. Good evening, everyone. Thank you very much for the opportunity to speak tonight. 86% of surgical deaths occur due to an emergency, of which the emergency laparotomy is the most common procedure performed, bringing with it a significant 30-day mortality rate of 5 to 20% reported around the world. The urgent nature of these cases results in limited preoperative optimization and significant variation in patient management and outcomes. Therefore, it is essential to identify high-risk patients so they may be managed with care tailored to their individual needs to provide the best opportunity for survival. A number of different audits, both nationally and internationally, have been introduced in response to the high prevalence, high cost, and variable outcomes of emergency laparotomy patients. Locally, we have the Australia and New Zealand Emergency Laparotomy Audit, or ANZELA, and state-based audits, such as the Victorian Audit of Surgical Mortality. And in a more international setting, we have the National Emergency Laparotomy Audit, or NELA, from the UK. And this was a very large study of over 38,000 patients, which led to the creation of a well-validated scoring system that uses clinical variables to estimate a patient's risk of mortality within 30 days following an emergency laparotomy. This score is then used to inform our perioperative decision-making and, more importantly, aids in identifying the high-risk patient so that we may then institute targeted perioperative care pathways to ensure that those patients at the greatest risk of mortality are managed efficiently and appropriately for their level of risk, with the ultimate goal of reducing mortality rates and providing the best outcomes for our patients. All sounds well and good, but what if the NELA score is no longer as precise as it once was? We know that the NELA score is very good at distinguishing high from low risk patients. But in Australia, what we still do not know is whether the NELA score accurately determines how high risk these patients are. So what this means is that if the NELA score predicts a 10% risk of mortality for a given patient, whether 10 out of every 100 of these patients will actually die. In essence, we do not know whether the NELA score is well calibrated to the Australian population. And this knowledge helps us in giving patients meaningful information about their surgery and its risks. And it helps in the allocation of hospital resources. So it is essential that this score is precise, which leads me to the aim of this study, which was to determine whether the NELA score is well calibrated to the population of emergency laparotomy patients at University Hospital Geelong. This was a retrospective cohort study that evaluated all patients who underwent an emergency laparotomy at University Hospital from July 2017 to January 2021. The inclusion criteria of the study was defined by the inclusion criteria used for the National Emergency Laparotomy Audit. Data was collected from the General Surgery Database at University Hospital, which is a prospectively maintained database of all emergency laparotomy patients. The data retrieved included patient demographics, NELA scores, post-operative destinations, and post-operative outcomes. Now, we use standard statistical methods, including a Mann-Whitney U-test to analyze median Neela scores, and the indirect method of standardization to calculate the standardized mortality rate. And we use Bayer's method to calculate the confidence intervals for the standardized mortality rate. 309 patients were included in the study, and from here, 24 patients were then excluded due to incomplete documentation, leaving us with a final sample of 285 patients from which our analyses were run. Now, this is a generalized depiction of the cohort on a histogram with 125 males and 160 females. And as we can see here, unexpectedly, the majority of the cohort was between the ages of 60 to 89. Now, of the 285 patients analysed in the study, 164 were discharged to ICU or HDU postoperatively, and 66 went directly to the ward. There was one intraoperative death, and 54 patients had no documented postoperative destination. Now, I would like to note that patients who were discharged within 30 days following their emergency laparotomy were assumed to have survived for the full 30-day postoperative period. And this meant that we had 267 patients that survived the full postoperative period, leaving us with a total of 18 deaths.
1 minute, 1 minute.
Thank you. Now, the blue bars seen here in this graph show the actual mortality rate grouped by Neela score, whereas the red bars show the mortality rate as predicted by Neela. And what you can see is that the higher Neela scores had a greater mortality rate. However, what is also apparent from this graph is that our observed rate for all risk groups, but especially for our high-risk groups, was significantly lower than expected. Overall, this produced a standardized mortality rate of 57%, with the upper limit of our 95% confidence interval being less than 1. This indicated that the total observed mortality was approximately half the rate predicted by Neela. So to reiterate, mortality following emergency laparotomy at University Hospital Geelong was approximately half the rate predicted by the Neela scores. Thank you.
Thanks very much, John. Damian.
Thanks, John. So interesting result there. So Neela is clearly a validated tool. So what do you think are the factors or differences in the population at Geelong that has led to such a significant difference in the rate?
Yeah, look, I'm not entirely convinced that it's necessarily attributed to differences at University Hospital. I mean, every hospital is going to have their own sort of standard care practices and differences and with regard to how patients are going to be managed. But I feel like the majority of the discrepancy between the predicted mortality rate versus what was observed is principally due to changes that have been implemented from the changes that were recommended by Neela when the score was originally introduced several years ago. Many of those have now become sort of standard practice in our perioperative care pathways. And so in a way, the Neela score has kind of become a victim of its own success in that by implementing those kinds of changes, mortality rates have been reducing, which is terrific, but at the same time, it's then resulted in the Neela score becoming a less precise tool for predicting mortality.
So what do you think those changes are that have been implemented at Geelong?
It principally comes with regard to by earlier identification of the high-risk patient, by earlier recruitment, of consultant involvement, earlier introduction of antibiotics, and then post-operative discharge to ICU or HDU, which I feel is probably going to be one of the most influential factors in determining mortality rate. It's known that post-operative complications are independent predictors and are the most influential predictors of outcomes overall. And so I think potentially by having a higher rate of discharge to ICU or HDU post-operatively, therefore allowing for that much closer monitoring and more rapid management for any potential complications, that's therefore enabled a more improved mortality rate at University Hospital.
Okay, thanks, John. Daniel?
So when comparing your outcomes to the sort of validated Neela score, their 30-day mortality is a 30-day mortality as opposed to a live at discharge, and therefore presumed 30-day mortality. And as your graph showed, a huge percentage of those emergency laparotomies are, in a geriatric population. And so as surgeons, I think it's very easy for us to pat ourselves on the back when we discharge the patient and think we've done them a great service, to then find out that actually Betty died the following weekend. So, I think that it might be worth considering, cross-referencing against the birth, deaths and marriages department to obtain the 30-day mortality to if you really want to sort of scrutinize the validity of it. And then the second question, I suppose that's partly a comment. The second question I had was, do your geriatric patients get a geriatrician review as part of their emergency laparotomy pathway?
Yeah, so I mean, a review by a geriatrician is as you very well be aware, is the 8th key performance indicator for the ANZILA, and as the data is currently suggesting, that's certainly the lowest performing key performance indicator, sort of across the board. At university hospitals specifically, generally no. So the vast majority of the patients are not receiving a geriatrician review. Certainly preoperatively is less likely, and I suspect that probably has a lot to do with the surgical urgency. That in some cases it's not necessarily feasible to get a geriatrician to review preoperatively, and in those cases where perhaps you have a little bit more time up your sleeve before taking the patient to theatre, then in those cases that's certainly an area for improvement to try and introduce further geriatrician review, and which naturally has been shown to improve patient outcomes.
You might get even better comparison.
Yeah.
Thanks.
Okay, thanks very much, John. That was great. And we will move on to our last presenter of the night, Emily Dool. Emily, are you there?
Yeah, hi.
Hi, Emily. Just going to share your screen. We'll see if we can see it.
Yep.
That's great. So whenever you're ready.
Hi, my name's Emily. I'm an unaccredited surgical registrar at University Hospital Geelong, and I'll be presenting my research looking at the choice of imaging and injury severity based on mechanism of injury in trauma patients presenting to a regional centre. So the reason this was an area of interest for me is that the bulk of the literature that is out there at the moment, it comes from tertiary trauma centres, and they have a vastly different cohort to the people that we're seeing in regional centres, particularly when we look at injury severity and the severity of the mechanisms. Additionally, there's an ongoing lack of consensus regarding imaging choices in trauma. Most recently, several large studies have come out looking at whole body CT, not able to confirm that there's a mortality or clinical benefit. So it's certainly a topical issue that I wanted to look into. I decided to focus predominantly on motor vehicle accidents as our most prevalent form of trauma coming through University Hospital Geelong, compare it to other mechanisms of trauma in terms of imaging choices and severity, and then see whether we could use this information to rationalise our use of imaging in motor vehicle accidents, particularly low-speed MVAs, which we are seeing a lot of in Geelong. So I did two main comparisons in our data set. The first was motor vehicle accidents versus other mechanisms. And the second was to look more closely at motor vehicle accidents. I split them into high speed versus low speed. I looked at two main factors. The first was imaging modality, in particular whole body CT versus more selective approaches. And then the second was injury severity score using the validated scoring system. And they were split into three groups: no injury, minor injury, and moderate to profound injuries. Looking firstly at motor vehicle accidents versus other mechanisms, we had 500 trauma patients retrospectively collected included in this data, and 220 of those were motor vehicle accidents. We had a really wide demographic of patients with an age range of 7 to 90 and an injury severity score range from 0, so no injury, to 34, which is profound or life-threatening injuries. Looking at the choice of imaging, the thing that stood out was that motor vehicle accidents had a significantly higher rate of whole body CT when compared to other mechanisms, and a lower rate of selective CT. So 56% had a whole body CT, only 26% had a selective CT. In other mechanisms, these two were more even, both between 40 and 45%. Interestingly, when we then looked at the injury severity, motor vehicle accidents had an incredibly high rate of no injuries identified. And that encapsulates both radiological injuries, but also soft tissue injuries requiring an intervention. So 73% of patients who had motor vehicle accidents didn't have injuries identified and didn't need active treatment after their accident. So this seems out of keeping with the number of whole body CTs that we're seeing in this group. So to delve further into motor vehicle accidents, I looked, as I said, at high versus low speed. Speed was known for 203 out of our 220 motor vehicle accidents, and the cutoff for low versus high speed was 60 kilometres an hour, which was taken from the Trauma Victoria classification between the two. High speed had a significantly higher rate of whole body CT, as expected, but low speed, we still found that whole body CT was the most commonly used imaging at 43%. So as I said, significantly lower, but still a large number of patients getting whole body CTs. When we looked at the injury severity between these two groups, unfortunately, due to the relatively low number of moderate to profound traumas in our cohort overall, we fell just short of statistical significance. However, there were some really pertinent findings that I still think are worth looking into. So of the low speed MVAs in particular, none of them had more than minor injuries identified. So 25% had minor injuries and 75% had no injuries. More interestingly, of those 25% that had minor injuries, all of them were isolated to a single anatomical region. So when we look then at the fact that whole body CT made up 43% of these patients, obviously there are other accident factors and other patient factors that will come into play, and that will always be the case. But it still seems like a disproportionately high number when we look at the pattern of injuries that we're actually seeing in these patients. So I think that the strength of this research lies in the fact that it gives specific insight into traumas presenting to regional centres. Regional centres see large volumes of trauma, but we're grossly underrepresented in the literature that's out there, particularly, as I said, in terms of injury severity. Our mean injury severity is 3. The mean injury severity of the 2 largest studies that we looked at was more than 20. So it's not really applicable. Our data, though not conclusive in some of our areas of interest, is highly suggestive that whole body CT may not be necessary in low speed MVAs, or not all of them at least, and selective imaging, either with CT or plain films, may be an appropriate path for some of these patients. We would really like to expand our data set, hopefully to capture more low speed MVAs, but also to allow us to look into other parts of the mechanism, such as specific mechanism, rollover versus hitting a stationary object, that make it higher or lower risk and can help guide regional doctors in their imaging choices for trauma patients. Thank you very much.
And thanks very much, Emily, for that presentation. Damian, first question to you.
I think you sort of answered my question, Emily, but so did you look at more specific mechanisms of injury in the low speed MVA, such as front impact versus side impact versus passenger side impact versus rear impact? So
no,
not just about intrusion or rollover, because those tend to be associated more with the high speed MVAs.
Yeah, absolutely. So that is definitely something that we want to look into, because as you said, that's probably the next most significant factor that we really haven't addressed yet. As people have mentioned earlier, manpower can be an issue, and we definitely want to expand our data set to capture more accidents so that we can be properly powered to look into those things, because I do think they're really significant.
And also, did you correlate the imaging that was done with the patient's symptoms or present a clinical features?
No, because we were a retrospective study at this stage, the clinical features, as I'm sure we've all found, particularly in a trauma setting, can be very variable. Particularly, in the urgency of the situation, it's not always very clear what the examination findings and symptoms are. So that wasn't something that we had good enough documentation to do. But if we were to do something prospectively, that would be something we would want to look at by bringing in a standardized form to collect that data so it can be more reliable.
Okay, thanks. And Daniel.
Thanks very much, Emily. So in terms of, if I followed correctly, the conclusion was that you think that there's a reasonable number of patients who could get away with either a selective CT or a plain film or nothing, rather than a whole body CT. Did you look at any of the sort of numbers needed to treat or numbers needed to harm in order to, you know, actually get a clinical benefit for anybody by reducing the number of whole body CT versus the propensity for a missed injury from a CT?
Sorry, I don't have the number needed to treat. What we do have is there's another paper that's been pulled out of this same data set, and that did look into missed injuries found at tertiary or after tertiary. In total, in our cohort, we had 6 missed injuries. And interestingly, they all occurred in patients who had had a whole body CT as their initial imaging of choice. And either the injury hadn't been captured on that because it was a peripheral injury, or it had been misreported on the initial scan. So certainly it is something to consider. It's not something that we found was significant in our particular cohort at this stage. In terms of the number needed to treat, I guess the benefits are twofold. Radiation is becoming obviously less of an issue as technology gets better, but not something to discount. And the cost benefit is of the scans in terms of the Medicare benefit scheme. But secondarily, in that other paper, we found that patients who had a whole body CT had a longer length of stay, possibly due to wait time for scanning, based on my experience at University Hospital. But that's sort of a secondary measure that reduces the cost by doing less and more targeted scanning.
Thank you. Really true to your point, but I reckon all those CTs are paid for by TAC rather than Medicare. But
that's true, yeah. Yeah.
Okay, thanks. Thanks for that, Emily, and thanks for your presentation. And that brings us towards the end of this evening. First of all, I'd just like to thank you all for the work you put into the research and the presentations tonight. It's been a really great evening, and the effort you all put in shows. They're always really enjoyable evenings. On all your behalves, I'd like to thank Daniel and Damian for the time they spent tonight listening, questioning, marking your presentations. Thanks very much for your support, guys. The recording of tonight's presentation will be posted in due course on the college website. And in terms of prize winners, those decisions will be made after all the sessions, and there's 3 sessions altogether, are completed, and the winners of the prizes will be notified by email. So once again, thanks all for your attendance, for your presentations tonight.
very high quality presentations across the board. Well done, guys. Girls.
Yeah, good job, everyone.